Pectus carinatum is characterized as a sternal protrusion deformity that occurs in approximately 1 in 1,500 patients. This deformity itself can cause considerable amounts of psychological stress and anxiety to our patients, and it is this stress that leads them to seek some form of correction. Historically, we've treated this with surgical approaches. However, the invasive nature of it has led us to look for other non-invasive treatments, specifically compressive orthotic bracing. In order to assess pectus carinatum deformity severity, as well as to create a custom-fit brace, we do need to make certain measurements of the chest wall. These at present are done with tape measures as well as calipers, and then a sketch of the chest wall contour is created, and from that we can create the brace. As you can imagine, this can be time-consuming and cumbersome, and certainly there's an amount of inaccuracies that can be inherent in this process. We've been looking at the use of a 3D sensor system called Structure Sensor. It's a small device that's easily attachable to any iPad. The way we use it is the patient stands in the middle and we walk around them scanning their chest. This image is then converted into a 3D image, a representation of their chest wall, and this image can then be rotated, flipped, twisted for the patients to see. Subsequently, we then take a cross-sectional image at the level of the greatest deformity. From that image, we can then look at measurements of the chest. This is a quick and easy form of measuring the chest and certainly has more objectifiable data. Furthermore, we can take multiple images of the chest over the course of treatment. We overlay the pictures on top of them, and you can then see a change of the deformity over the course of therapy. The purpose of this study today is to demonstrate the feasibility of using this 3D imaging system in an outpatient clinic setting, as well as to show that the images can provide accurate dimensions of the chest wall. This is a retrospective observational study. We've looked at 13 patients who were scanned as well as measured clinically at the initiation of bracing. We then compared the measurements of the anterior-posterior as well as the transverse dimensions between the clinical measurements as well as the body scan. We then calculated a Pearson correlation coefficient. That value was 0.7 and 0.5 respectively for the AP and transverse dimensions, thus showing positive correlation. So in conclusion, we have shown that this novel imaging system is feasible to use in the outpatient setting and also has shown to be accurate in measuring the dimensions of the chest wall as evidenced by the positive correlation. We're very excited about this novel imaging technology and feel that there are a number of different directions that we can use this system in the future, even within the realm of pectus deformities. Specifically with pectus carinatum, we hope that it'll help improve access to patients in rural settings. We hope that the quantifiable data obtained from it will be able to individualize bracing protocols. And finally, we hope that it will allow patients to have more incentive to be more compliant with their therapy. And finally, with pectus excavatum, we hope that its use can help eliminate the need for CT scans as well as the radiation associated with it.